a circle. So I don't like when people are seeing the back of somebody else, but we'll do it because. So, my name is Jaime Gofin. I was born in Uruguay, okay, where I got my MD, and I started to work in public health there, and I got a scholarship to do an MPH, Master of Public Health. The scholarship was for the School of Public Health and Community Medicine in Jerusalem. So I went to Jerusalem, I got my MD there, my MPH, sorry. In the meantime, many things happened in Uruguay in those days, 1972, real terrible things, okay? And I was invited to stay in Jerusalem, so I stayed in Jerusalem. I became member of the same team I will share with you what, that all this model was created and developed. And then there I became the director of the health center. I moved around the world in several countries. I started to be related to George Washington University in 1992. And there, George Washington decided in 96 to create a community-oriented primary care, COPC, MPH program. And that was the first one. And then I was invited to be in charge of the program. This was 2008 to 2009. And there I was invited to come to Omaha, to the College of Public Health at UMC, to develop, to create and develop a community-oriented primary care MPH. That's it. I can tell you about my family, but not now. So, the idea is hopefully to share and discuss health at the population level. We are now here in a building of a medical school. That in itself means something. And to put this means something else for me. Maybe I'm wrong. A service also to discuss a service delivery of health care that is called community-oriented primary care, and also a little bit about the social role as health professionals. So, if we were in a class, I will ask what you see there, but we are not in a class now. So, this is what usually we see if we are on the sea. And this is we can see it. What's happening if we don't use the microphone?
Okay, sure. Well, it's still recording. Okay, for the audio we need it, I think.
Okay, now
So
it's okay?
Is it better if we stand farther away from the stand? Okay, so I think it...
To be far away
yes,
from there?
yes.
Okay, it will be. Remind me if not. Okay, we see. So in the recording you will cut this. Okay, this is what we see, and we can stay there very quietly and forget, but not. We need to be aware of what is there. This is what is there. And that means a lot. And it depends on which situation you are, in which role you are, and where you are discussing or talking. But something is below, that is more, is bigger. In my pocket. If I stay here. Thank you. Okay, so this is what we see now. And this means larger to what we saw before, unknown by us, and who knows what is going on there, and what are the problems that are there, and what are the problems of the people, how they are suffering. So what is our responsibility in any discipline? Not only to see and take care of the tip of the iceberg, that in medical care we call it the demand, but to identify and to act on the needs of a total community. This is our role. This is in the way which I see it, but you can have your own, and it might be different. And when we say the needs, we are talking about something that in the last 20 years became more and more important in the medical field, in the health field, that is the determinants of health. In the past, we used to say that genes and biology was the main cause of health or not health. Today is different because many things are being detected, and we see there that medical care is also a determinant of health. And this gives to us a big responsibility in the future, in your case or my case. And medical care refers to two things: access and quality of care. Many times, people that are talking about the reform, they say that the solution to the problems that we have is to have better access. It's not enough. Access is one, but once that you are in, you need to get a quality of care. And when we talk as social and socioeconomic environment factors. So we divide the services according to the level: primary care, secondary care, and tertiary care. Did you have any discussion about what is primary care? No. So primary care, primary care, I continue. Primary care is where the first contact between an individual in society, on the population, and a person of the health service system. First contact. Secondary level are the hospitals. But which hospitals? The ones that are mainly in the rural area. What that means? Sorry if I'm talking and giving to you my back.
Dr. Gofin, do you think it would be possible to use this mic instead?
Yes,
And
yes.
I'll just turn this one off. I'm sorry.
No, it's okay.
Yes. Okay, so, yeah, thank you, sorry.
That's it.
Yes.
Okay. Secondary care, we were saying that are the hospitals in the rural area, mainly rural area, but that are identified by having the basic services. It means internal medicine, pediatrics, and general and family medicine, sometimes gynecology too. And tertiary care are the hospitals that have everything, like here at Crinton or UNC, that they have all the specialties. So why we insist on primary care? Because 80% of the problems in any population, in any community, are expressed in primary care. And in this country means family practice, internal medicine, and pediatrics. So 80% of the problems are expressed, are coming, are seeking solutions in primary care. And that gives to primary care what we call the value. And it's also considered in many places as the essential component of the health service system. But more than that, health is better in regions in the United States with more primary care physicians. And also that when there are more primary care providers relative to specialist care, costs are lower. And both of them are really important. So a little bit about who we are. Who we are in the sense, I will say, I am public health, you are medicine. Let's assume. I don't know what will be your future, but so medicine is clinical individual care. The focus is individual patient care and addresses mainly diagnosis and treatment. This is in general. What about public health? The focus is population health and addresses the health promotion and prevention of diseases. Now, this is trying to see the reality. You see there that primary care, as I mentioned before, is the responsible of 80% of the problems of health care in any population, while it receives only 1 or 2 or 3% of the budgets. And this is real in almost everywhere all over the world. And that in itself is more than a red light for me. Now, to see a little bit more about what happened in this country. The United States spent $2.5 trillion in healthcare. That is double of any developed countries, compared mainly to the north of Europe. Yet, the United States ranks 50 in life expectancy and 34 among developed countries in infant mortality. Both things, expectancy of life and infant mortality, are taken as indicators of the state of health of any population of any country. So with these two, you identify what is going behind that. And these are the challenges. People are saying that we will not be able, will not be able to maintain the cost as it is. This will explode. This is what economists say, and many people in the healthcare systems also say the same. And the difficult or the terrible thing is that the costs are one thing, but the outcomes are totally different to the cost, in the sense high cost, but the outcomes are really not good. This is another reality. These are results of studies done in the United Kingdom, but also in the United States in the 1960s, repeated in the year 2000, published in the New England Journal of Medicine, and they went to find out what the people felt in the last 2 weeks. So the numbers are round. In population of 1,750 felt ill in the last 2 weeks. Of them, 250 consulted. Of them, 1 was hospitalized, and 1, it was in a teaching hospital. So these are the facts. How we play with this, how we make interpretation of that. This is interpretation, for me, for us, that the view that we have of the community is very, very limited. And this you need to think about yourself, what you are doing, whether this is correct or not. On the other hand, in primary care, according to what I said before, potentially, and that is the meaning of the interrupted line, are able to take care of everything. Means because the fact that they are taking care of 80% of the problems, it means they can be able to take care of everyone there, to be able to know and to take care. So we need to change that, I think. So how? We need to move from not only the disease, but the person, not only the person, but the community, not only biological, but social determinants, not only the physician, but the health team, not only the hospital, but primary care, and not only health services, but all the sectors that are related to the health of the community. And as you see there, education, welfare, social services, culture, agriculture, industry, faith, and also 3 points there that you can add other ones. So what we mean by that is what we understand by community health. You can see there, you read by yourself. There is not only one definition, but this is the one that we used. Okay, this is individual care that you are doing or you are learning in the medical school. This is what we do every time that we see a patient at an individual level. Okay? In community care, there is similar steps, but with different instruments, different methods, but you are doing the same. One difference is that one, the community care, is a practice that initiated. Here is the patient.
So if one will say, what is the summary of this difference between the two? Here is individual-oriented, and care is based on the demand. While in the community care is community-oriented, care is based on identifying needs and also has community involvement. So here is that particular model that is called community-oriented primary care in the literature, and many times you will find that COPC. That is the acronym that identifies this model. Sidney Clark, a family doctor in South Africa, was the one that pioneered the whole movement, and this is the definition that he gave to that. Care of the individual that is well or sick or at risk. It's not only those who are sick, and also promoting the health of the community as a whole. The origin. This started with these two family physicians in 1940, 41, 42, in primary care in the rural area of South Africa. They started by combining prevention and preventive. They started to consider the community as such, as a whole, to take care of the cultural values, to take care of the beliefs, to organize the community, to take care by themselves related to mainly to nutrition, but not only nutrition. This was the area, still is similar to that, but that was the area. This is the team. These are the two in the center are Sidney and Emily Clark. And these are people from the same community that were trained by them, and this is something new in those days, to be nurses or health educators or recorders. So what is the evolution of that? Polela is the area, and it's called and it's famous in that way, Polela. So they were able to reduce infant mortality and infectious diseases. So the government saw that this was useful and decided to create 200 of these community health centers. By the way, that was the first time that the term community health center was used in Polela. So they decided on 200 to create. They were already on 44 were established. Then it was a change in the politics, or the politics in South Africa, when the apartheid came and they closed all the health centers. As a consequence of that, the team emigrated, left. Most of them, some of them came to the United States, but most of them went to the Adasa Community Health Center or School of Public Health in Jerusalem. That was the name, and that was there. And many things that I'm going to say to you were developed, not created, developed in this particular place. Today, COPC is one of the approaches suggested as a provision of integrated care model of medicine and public health. So what are the principles? What is the conceptual framework? First, we take responsibility of a total defined population. If it's a school, all the children of the school. If it's a factory, all the workers. If it's a neighborhood, all of them. And it is not easy to define the community, and in the States it's very difficult because people can go anywhere and come from anywhere. Second, care is based on identifying needs. So we go and find out what are the problems, but we are able to detect that while needs are infinite, resources are finite. So in that sense, we need to prioritize. We'll select one or two or a set of conditions that are interrelated. And then a program of intervention that takes care of promotion, prevention, diagnosis, treatment, rehabilitation on the physical, mental, and social dimension. And fifth, community involvement. The difference between the four ones and the fifth one is that the four ones are decided by the services, by the team, by the organization. The fifth one, no. The fifth one needs to be decided by the community, whether they are willing to, whether we like to, and whether they are accepted to be able to work together. Only to give an emphasis on this background of the conceptual framework, it was a study done by Canada, Service Research Foundation, on 6,000 articles to find out about primary care and public health. And review of the articles, they say the majority of papers didn't identify use of any theory, with a notable exception of papers using COPC model and other two models there. It's only to emphasize the value of this theoretical framework. But this is got together with this methodological one. It means we need to define the community, to characterize who are they, to prioritize, to do a diagnosis of that particular selected condition, to intervene, to evaluate, and to reassess. What that means, again, we think what we did was okay or not, and then if yes, or if we decide to continue with modification, we go to another one, another problem in the same community. The experience, our experience, shows that we prefer, Now, also, the model has this, it's proactive. Usually, services are reactive. People come seeking care, and I react by providing care. Here is different. Outreach, because people are not living in the clinic. They're living in their houses, in their places, work somewhere else. Multidisciplinary team, because the physicians alone are not able to do it, everything. So you need to have a team. And intersectorial cooperation, because more and more we know something that we didn't know in the past, that medical care alone cannot solve the health problems on any population. So we prefer to use this, the methodological and the conceptual, because some people take the methodological, the circle, and it's very technological, and it's not. It has principles that are considered also as a way to maintain or to promote social justice. And these are the effectiveness shown in different countries. As you can see, all of them are positive results. So we say before that potentially primary care can be able to know everything, to take care of everything, but it's not. So in that way, we can say, according to the results, according to effectiveness, that community-oriented primary care is able to do that. Together with the teaching hospital, it's not one against the other, but together, and not alone that one. That is the main message. So these are questions. It's a rhetorical question. So don't try to answer. These are international organizations like the Pan American Health Organization, the World Health Organization, others that are also considering as this one option to change the healthcare system. In the United States, Jack Geiger was a physician that went in the 1950s to Polela, to that particular place in South Africa. He came back after being trained there. He said what he said. Look at what he said there. The concept denominator is clear to all of us? Okay. Geiger came to the United States, as I said, and created, together with somebody else, two different health centers, one in Boston and another one in Mississippi, based on the same principles that were present there in South Africa. And this was the origin of what today we know as the development of the community health centers, which are 1,200 all over the United States that are taking care of approximately 20 million people. So in the past, in the United States, development after the creation of the two In the present, it is applied in several services in the country, mainly in teaching programs, but also in practice, and also is referred in publications about reform, and I will see that later. And the future, a question mark, the COPC and the Affordable Care Act. So these are different practices of COPC. Let's take, this is one example. In a practice of 3,000 people, a private practice in Rochester, they define the community as all active patients enrolled in the last 2 years. And they also created this pact, it means patient and community together. And they both decided what are the priorities, they intervene on that particular problem, and this is the evaluation done by themselves. This is another type. It's in Parkland Hospital in Dallas, where there is largest application of COPC in the United States. Only one thing, how this started, because the hospital had a health center, and they had to close the health center because of budget problems. The people met there, discussed, and suggest by themselves to create a new, small, additional tax. Based on that, today there are 26 primary care settings doing COPC with this type of priorities decided by themselves in what they call community conversations and providing primary health care. And the evaluation shows positive results. Now, in the last 3 years, these journals, that very prestigious journals, referred to COPC. They didn't write about COPC. It was about the reform, but they mentioned as one of the options community-oriented primary care. And what were it's my fault. Okay, what we are considering in this article, integration of public health and medicine, a cornerstone in the foundation of primary care. Providers work with the community and not, as usually is, in the community. It's not the same, it's totally different, conceptually and humanistically, if you can say. One thing is to work in, and the other is with the community. And for that reason, I like to put in capital letters. And moving primary care outside the medical offices. So the Affordable Care Act is suggesting these 3 things: increasing the workforce, education training, community health, incentivize population health through new models of care that need to be developed. In an article that we just published in Primary Care and Community Health, we thought and we think and we suggest that there are 4 different actions to be taken care. One is to build coalition and partnership with all those sectors that are taking care in different ways and totally separated and very fragmented on the same community. It needs to be together. Second, team development, and not to continue to have this situation in which the physician is the main responsible and the one that needs to do everything. No, it needs to be a group of physicians together with others to expand the role of other allied health professionals. Third, information technology is changing the whole situation. In South Africa, they wrote cards. In Jerusalem, we wrote cards. We didn't have computers. Now it's totally different with the information technology facilitates the whole thing very quickly. Here, in all the studies, exercise that I'm doing with the students, they go to the internet and they immediately get results of everything that we are looking, of certain zip code, of the people who are living there, who are they, what are the main features that characterize that community. And four, obviously need to change payment, because payment today is fee for service. And promotion, nobody pays. Prevention, nobody pays. And for that reason, the suggestion is to be capitated payment and to see what will happen with new organizations that will be called accountable care organizations. So these are countries in which COPC is practiced. It's not practiced in the whole country, but it's practiced in regions or districts, even using different names as on the right side. One example how we can move from teaching to the practice. We started in Spain with workshops in 1987, and throughout the years, every year, one workshop of 40 hours, 5 days in a week, concentrated with 35 physicians and nurses. We were able, the situation was able, because of this model, to have the creation of a working group, not by the university, not by the government, not by the Minister of Health, but the same physicians, the family physicians, decided to create a working group. We started with 4. Today we are 25 people working. Then the residency program in family medicine was extended. The first 2 was in Catalonia, but the third one is for the whole Spain. Today, there are 34 primary care teams applying COPC and 72 health centers in a network of community-oriented health centers. So what we have as a teaching, these are different programs that we have with the community-oriented MPH program. We have this is 45 credits, the first one. The second one, the certificate, is 18 credits. It's feasible to do it in 1 year. The MPH takes 2 years at least. But also we have dual degree with the physician assistant program and also with the MD, MPH, that includes the COPC MPH program. We use a textbook, and we consider this important. Of course, we consider important because we wrote the book, but important for the students, it has an important element for going through the whole MPH with a textbook. The textbook has 8 chapters on community health, community-oriented primary care, and a new approach to public health that we call community-oriented public health. Section 2 has 16 case studies from the 5 continents illustrating this type of model, and also each chapter includes discussion questions and review questions. It means it's easy to use in the academic environment. These are the places in which these case studies were done. These 16 cases are in different continents, as we mentioned, different levels, different approaching, but only 11 are COPC and 5 community health care. The authors are graduates of our international student in Jerusalem. We had an MPH International that throughout the years, 800 international health workers, mainly physicians, got the training from 90 different countries. And the target population is throughout lifespan in the book, from children to pregnant women and to elderly people. So, that is the end again. I like to do where we are. So that is the demand. And that is a question mark. Again, capital letters. So 3 non-rhetorical questions. Could we be concerned only on the demand? How individual healthcare should be bridged from and to the health of the population? And what is the social role of any health professional in population health? We are coming back to that, hopefully. So, again, the idea is one plus the other, no one instead of the other, and no one more than the other. In that way, that's it. Nice. When it works, it's nice. And this is a question. But this is a question to ourselves. So if we are going back, question, comments, suggestions, critical views. I don't know whether it's correct from the English point of view because, again, it's not my language. But purposely, with different color, I use could, should, is, and means something. I don't know exactly what means, but I have an idea. But from the point of view of looking to ourselves as a professional and as a role in the society. Any question? Yes.
Current model we have where patients or they don't feel like they're very involved in their health to this new model. Like how do you spur community involvement?
The community involvement in itself is a factor in the whole thing. It's very much related to the local culture. It's related to the fact that we as professionals are not taught to be involved with the community. We are the owners of the knowledge. It's related to political situations in which the community is involved or not. It depends. It's a lot of problem, no question, but it's only by knowing the problems we may find a solution. The community sometimes they do have some kind of structure or organization that been together, sometimes formal, sometimes informal. But sometimes you also have political leaders there that not necessarily represent the community. I'm not talking about the United States, everywhere. So again, it's a problem, but a problem, sorry, it shouldn't say a problem, it's a challenge, by which the idea is to have a mutual understanding, professionals and the community, and mutual respect. And start, we say always that start not only one, but at least two. I was, very personal, but I was teaching community health there, the community involvement. And then I decided to stop to teach that, but to become a community volunteer in the neighborhood where I live. And that was an experience that was very useful for me. Of course, I became the chair of the community health, the whole thing, that because of experience. But this is important, to be there. Questions? Yes? It's a problem, no question. Look, there are many different phases to this. On one hand, remember, we are in the middle of industry, a word that I didn't use in the past, but I got used to. Industry made by insurance companies, pharmaceutical companies, and medical care organizations. They constitute 1/6 of the workforce in the United States, in general. And there are taking care of something like 40% of the lobbying to political decisions. Now, this needs to change from the top and from below. From the top, the question is whether policy can come in a way that to distribute the money in different way. But to distribute the money in different way, you need to face problems. Why there are so many cesarean sections in this country compared to Canada? A little bit north. And similar thing with others. There is a tendency, why? To produce more tests. One person goes to one doctor, several tests. Goes to the other doctor, again the same test. And the test costs money, but the test imply reimbursement to the physicians. It's a complicated one, but it doesn't mean that we shouldn't be aware of that. Should be conscious of that and find a solution together with others. I'm sorry, I don't have a formula. There is not a formula. There is a situation. Policy, but also medical organization going together. Yes, yes, yes. Look, the Institute of Medicine that belongs to the National Academy of Science is suggesting the same thing. Also using the COPC, but not only COPC. And they are suggesting that because economists say that this is unsustainable. Yes?
So currently this is something that you have to, like this kind of education is something you have to just seek out, going for this MPH and COPC. And I'm wondering, is there a way for this to be integrated into medical education that every doctor gets this? It seems like very important information about community awareness. So would you see somewhere in the future where this being integrated into just mainstream medical education?
One thing are wishes and the other thing are options. Wishes, of course, but it will not happen for tomorrow. The only thing that we are aware of, and something is a trend, more and more medical schools in the country, this country, and other countries too, are incorporating epidemiology, social behavior, social science, in that way to give to understand again that the question is not only the patient, not only, I said, not only the patient and the bed, but all the total population. So there is a tendency in medical schools in the United States to open the education on mainly on first years on subject, topic, dimensions that are related to this population health. But we need to be aware that sometimes, or many times, are included but diluted among the many other things that we need to learn to be an MD. About the George Washington experience on the COPC. When I came here, I said, okay, it's the only one in the country. Then we created one in Omaha. And say, how can I say now that it's a problem? So we say that there are two in the country, and the one here in Omaha is the first one in the Midwest. And that is nice. Okay. More questions? Any question to me or to COPC? No problem. Ask. Yes. I am not in the last almost 5 years since I started to work here to develop this new program. I am not involved in research. Previously, and there are publications in that, I was mainly involved in evaluation of community health programs and also evaluation of teaching. But other people are, and look, one suggestion. If we go to Medline, PubMed, and trying to find out about community-oriented primary care, I will suggest two things. One, not only go to Medline, also with being very careful, go to Google. Google has a good thing, but you need to find a reference to everything that I said. And there to write as a term, community-oriented primary care, COPC. Because if you write COPC alone, it's terrible. As I said, it's very fun to see what people call COPC. And totally unrelated. But if you put the two of them, you will get things done based on research in the United States. Some people say that the COPC is very difficult to do it, or difficult to do it, because it requires, among other things, skills. You need to learn how to do it. We think that if we have more training, more people will be trained. But also to have an environment, what we call a reform environment, this is a positive element. Because people are talking and trying to find out a particular solution to this particular situation. And in Jerusalem, I was involved in the three, in the practice, in the teaching, and in the research. Yes? Okay, it depends on the, this is called need assessment, really. And now we are also a rapid need assessment. But it's also mainly based on two things. One, by asking questions to the people, and by examining the people. Together with, as much as possible, find out data that is already available in two different sources. One, in the clinics in where those people were already attended, or are being attended, and also like the Department of Health of the Douglas County. There you have a lot of information. Now, how this information is corresponding to this particular area, zip code, we did in these 4 years, we did the COPC concentration have 4 courses beside the public health courses. And the first one is called Community-Oriented Primary Care, Principle and Practice. And we do it by 75% of the time, the students working together with us, and only 20% our lectures introducing each one of the steps. But always doing this in a real situation. So first year we went to one word, you know, they say, okay, there, and we were there. And the students were able to identify a problem, diabetes. They created a proposal, and the last day they presented the proposal to us to be graded, but also provide that particular 50 pages to the health center. If they want to do it, they can do it. Second year, we did it in Ponca Clinic. Third year, we did it in the family practice of the hospital at UMC. And the fourth year, that was last fall, we did it in the school-based health center at the Kellum School, primary school, in North Omaha. You need to say 1, 2, 3, 4, 180. Okay. Any more questions? If you don't, we are not obliged to have questions. It's only because I said at the beginning to share and hopefully discuss. Teaching, now we will give 3 minutes. Teaching is not a unilateral phenomenon. It's a bilateral phenomenon. It's not only to provide information, but to create knowledge that eventually each one of the people who are listening to that are able to use. Because there is somebody who mentioned that education is not to create bank of information, but to create people to help people to create themselves. And I believe in that teaching. So for that reason I said, hopefully to share and to discuss. And we did discuss a little bit, and I continue to be at UMC. You can find me easily there. No more questions? Good luck.